Greetings and welcome to today's Healthcare Provider Program, brought to you by Living Beyond Breast Cancer. At this time, all participants are in a listen-only mode. This webinar is being recorded. I would now like to turn the program over to your host, Stephanie Washburn.
Hello, everyone, and welcome to today's Healthcare Provider Program on new perspectives and practices in palliative care. This is the second session in our two-part series, Caring Full Circle, Managing Your Needs as You Care for Your Patients. We're glad that you could join us. My name is Stephanie Washburn, and I'm the Manager of Healthcare Provider Outreach at Living Beyond Breast Cancer, or LBBC. I'm pleased to serve as your moderator today. In case you're just getting to know us at LBBC, we're a national nonprofit organization that offers trusted information and a community of support to people affected by breast cancer. This program is part of LBBC's Young Women's Initiative, which provides resources created for people diagnosed with breast cancer before age 45. This initiative began in 2011 when we were awarded a cooperative agreement with the Centers for Disease Control and Prevention to expand our programming. We selected today's topic because of its importance to the well-being of breast cancer patients and their loved ones. Our speaker, Dr. Kimberly Curseen, will help us understand the current landscape of palliative care. I want to recognize that many people are affected by the hurricane today, including Dr. Curseen and her community. She's taken some extra steps to join us today, and we just really want to thank her for that. We also thank Dr. Curseen for sharing her time and insights with us today, and you'll learn more about her shortly. We'd like to draw your attention to several LBBC resources that we hope will be helpful. The first session in this webinar series for providers, Workplace Safety and Emotional Health in a Changing World, was held on September 12th. We had a really meaningful discussion about self-care for healthcare providers. You can find the recording, transcript, and slides at the website that you can see on the screen. We also have a 4-part Innovation in Care series for your patients that kicked off on September 17th. The 2 remaining sessions will cover the role of testing in breast cancer and financial and time toxicity. Patients can register at the website that you see on the screen, and you're also welcome to join us. Please note that CEs are not available for this program. Today's speaker, Dr. Curseen, also gave a great presentation for patients called Empower Yourself with Palliative Care, which was recorded at our April 2024 Conference on Metastatic Breast Cancer. You'll receive links by email after this program so you can share the information with your patients and colleagues. This will also include a link to a healthcare provider blog about the distinctions between hospice and palliative care. Now let's move on to a few final details before the presentation. Today, we'll be using the chat to connect during the program. I can see that has already started, which is great. You'll see the chat icon at the bottom of your screen. We'll also be using the Q&A feature. Please submit questions for Dr. Curseen at any time. We ask that you frame your questions so they can be helpful to all participants. Our speakers will respond to as many questions as possible after the presentation. You can set up closed captioning by going to the button at the bottom of your screen. We will email you a link to the evaluation after the program. Your feedback is really important to us in planning future webinars, and we appreciate you taking the time to share your input. Now, just a few words about contact hours and CEs. This activity was approved by Montana Nurses Association, an accredited approver with distinction by the American Nurses Credentialing Center's Commission on Accreditation for 1 contact hour. It was also approved by the National Association of Social Workers for 1 CE. If you have registered to receive contact hours or CEs, you're required to participate in the entire live webinar today and to complete the evaluation by October 11th. You will then be emailed your continuing ed certificate by November 8th. Certificates of participation will also be available upon request for providers from other disciplines. None of the planners or presenters for this educational activity have relevant financial relationships to disclose with ineligible companies, except for the program's nurse planner, Lori Ranallo, who has been a speaker for Myriad Genetics. All of the relevant financial relationships listed for this individual have been mitigated. We are recording the session and will post it on the program webpage soon. We'll notify you via email when the recording is available. In today's program, you'll have the opportunity to learn from Dr. Curseen about changes in the landscape of palliative care, strategies for identifying and easing patient and caregiver distress, advocating for optimal patient care within the multidisciplinary team, evolving and prolonged relationships with patients across the continuum of care, and ways to cope with patient suffering. It's now my pleasure to introduce our expert speaker. Dr. Kimberly Curseen is the Director of Supportive and Palliative Care Outpatient Services for Emory Healthcare. She's also the Director and primary provider for the Supportive Oncology Clinic. The clinic provides physical, emotional, and spiritual care for patients with cancer at any point in their disease process. The clinic also assists patients with complex decision-making. Dr. Curseen served as the program developer and director of the Geriatric Palliative Care Clinical Services Program at the University of Arkansas from 2009 to 2014. She is board certified in internal medicine, geriatrics, and palliative care. Dr. Curseen was named one of the Palliative Medicine Inspirational Leaders Under 40 by the American Academy of Hospice and Palliative Medicine for 2014 to 15. She currently sits on the board of the Georgia Hospice and Palliative Care Organization and is a co-chair of the Georgia Cancer Consortium Palliative Care Working Group. Dr. Curseen is also a member of LBBC's Medical Advisory Board. Welcome, Dr. Curseen. We're happy to have you with us today. Please join us on screen to share your presentation, and I'll now turn things over to you.
Hi, thank you. Thank you so much. As I'm sharing my presentation, I just wanted to say I really greatly appreciate the opportunity to meet with you all today. So let's see. Sorry. And as we mentioned, I have no relevant financial disclosures, but I do have two personal disclosures. So just recently, my mother was diagnosed with hormone receptive positive breast cancer. And oddly enough, on the same day that she found that out, I also had an abnormal mammogram, and I'm currently waiting for a diagnostic one. I wanted to share that with you today because sometimes in healthcare, we often forget what it's like to be a patient because it's our jobs. And being on that side has really opened my eyes or just reminded me of a few things that I'm hoping to share with you. So all of your healthcare providers, so we won't spend a long time, but I just wanted to remind everyone what the scope of palliative care is. So palliative care is a specialized form of medical care focused on improving the quality of life for patients with serious illness, such as metastatic breast cancer. It addresses the physical, emotional, social, and spiritual needs of patients and families, and the primary goal is symptom management and providing relief from pain, emotional distress, and other burdens associated with the disease. In addition to this, we serve as an extra layer of support, so we don't replace any teams, but we support not only the patient's families as well as the care team. So when you think about the scope of what we do, because sometimes that's hard to pin down, because that's a very broad definition. I always like to say the definition of palliative care is almost a biblical one. We're going to take care of you completely. But it's really thinking about not so much of a specialty, but possibly a philosophy of care. So when we think about it as a philosophy of care, it makes perfect sense that we start palliative care principles and palliative care the minute you're diagnosed with a serious illness. Those principles still apply when you are going through that illness. And at the very end of life, which will happen to all of us, then these principles still apply at that moment. And also sometimes we use a lot of different terminology. So there were several studies that showed that patients were more comfortable with the term supportive versus palliative, because oftentimes when if you Google palliative care, hospice comes up, and that can be really, really difficult. So many of us have transferred our clinics or the names of our services to supportive care. So when you think of supportive care, we are just a slice of supportive oncology. And supportive oncology is a vital collection of services that all patients with cancer needs, because it follows them through the various stages of their illness. So palliative or supportive care in advanced cancer is the standard of care. According to the ASCO guidelines and even the updated ASCO guidelines, palliative and supportive care should be available to patients to maximize quality of life through all phases of illness. Palliative care is not equivalent to hospice, and hospice is a vehicle that delivers palliative care when a person is at the end of life. So many, many years ago, the evolution of palliative care in oncology, we started out as threatening, and we sort of had to fight to get a seat at the table. And then we progressed to the next phase where people were accepting and starting to think, hey, this possibly has value, but we're not entirely sure. Maybe we need you, but kind of not all the time. Now we have gotten to the phase where palliative care, supportive care is an expectation. It's a standard of care that all patients should receive because of how difficult the cancer journey can be. So what is our philosophy in palliative care? We focus on the symptoms. What I often explain to patients is that your oncology team is really focused on your cancer, and that's exactly what you want them to do. That's why you came. However, all the things that affect you or make it difficult for you to go through your treatment for cancer or tolerate this time in your life, those are important too, and they require their own due. They require their own time, and that's why I'm here. We try to help patients clarify and support patients and caregivers' goals. So if palliative care is done correctly, when patients come to us, we don't have an agenda. We do have opinions, but we don't have an agenda. And once we have clarified the goals, whether those are goals that we agree with or not, that's what we're there to support. And often that's what we're there to advocate for and help them work through and frame. We often live in a place where evidence-based medicine fails. So I always laugh is patients will come to me after they've seen 10 doctors and with the phrase, oh, they said that you would know what to do. And I'm like, well, if all these people didn't know. So this is when palliative medicine providers often become very creative, and it's our ability and our training to look at things holistically, the 30,000-foot view, and seeing how patients are put together, which helps us not only work through the uncertainty, but really brings together how we are able to manage really difficult symptoms. So where can your patients receive palliative care services? So I really want to highlight primary palliative care. So I can't see a show of hands, but I wonder if in the audience, do you think that you provide palliative care to your patients? And I say, and I believe that if you have ever managed your patient's pain, if you have ever sat with them a little longer while they cried, if you figured out how to get them to their appointments when they don't have transportation, then yes, you have practiced primary palliative care, which is incredibly important. And many cancer teams do this very well. When that care outpaces, then seeing people like me in outpatient or community-based care, where some of us are embedded in oncology teams or others have freestanding clinics, provide specialty palliative care. Of course, many people are familiar with hospitalized palliative care, which is providing that urgent care. And then home-based palliative care provided in private homes or institutions, again, brings the clinic to a patient's home to support people who have limited abilities to travel or too sick to travel. So what do patients with metastatic breast cancer and survivors actually need from us? For real, like what do they need from us? Well, I want to stop here and just set the stage and get on my soapbox for 2 minutes. No evidence of disease is one of the most ridiculous and insulting terms I have ever come across referring to patients who have had cancer or patients who are living with cancer. And I want to place that in your mind because if that is incredibly important. So when you're thinking about how your patients are suffering or your survivors are still suffering, oftentimes, what do they get? Well, there's no evidence of disease. You should move on. Well, if you have ever had a serious illness, I don't care what it is, but particularly cancer, you will have evidence of disease for the rest of your life. Their body is a roadmap of that illness and the remnants of it. So I want to just sort of put that in your mind. So when we're communicating with patients, that's incredibly important because the emotional support that metastatic breast cancer patients need, there's a lot of turmoil. These patients are living in medical uncertainty, as is like living in the pit and the pendulum. They're waiting always for the shoe to drop, but they're expected to figure out how to plan for the future while that future is no longer certain. And almost every one of your patients during their journey has suffered a medical trauma. So our team focuses on psychological support and trying to navigate and trying to make this journey easy to try to minimize that medical trauma. And a real big plug for integrating mental health professionals into palliative care teams is essential. So in our system, all cancer patients have excellent social workers. So they often wonder why they come to the palliative care team and they get another licensed clinical counselor. What that licensed clinical counselor is there to do is to attend to the mental health, in addition to other things they may need. We also have to think about, particularly for our cancer patients and our survivors, the social determinants of health. And the reason why is because what a patient has going on is going to affect what they're going to be able to do. That will affect their treatment and influence their outcomes. There's no way a young woman is going to be, or a young man, going to be able to do a clinical trial if they're the only person in their house that is working, and if they don't have childcare and the cancer center is located 2 hours away. That's not realistic. However, that creates disparities. And it's part of our job to think about those disparities and actually bring this other things that you may not have been told. Like all patients do cancer distress screenings. And many people are really honest on those screenings, but I often find that people don't always read those screenings. And sometimes people don't want to put those things down because they find it embarrassing. They think it will change the way you look at them. But in our clinic, we really break that down and try to think of ways and problem solve and advocate for our patients in order to bring that other piece that you really need to know in order to treat them, as well as make that connection. And then, of course, our bread and butter, we have to focus on the symptoms. So that's one of the cornerstones, whether it's pain, fatigue, psychological issues, all of that affects the ability, not only of your metastatic breast cancer patients who are doing fairly well, but of your survivors being able to enjoy the time. Because, going through cancer treatment is tough. I don't have to explain that to you. But if you're miserable afterwards, then as many of my patients ask, if I knew life would be like this, maybe I wouldn't have made a better decision. So the whole point is to live. So if the symptoms aren't controlled, it's going to be difficult for people to live their best life. So I want to make a run through some of the symptoms. And these are not all the symptoms, but I wanted to pick out some of the symptoms that I think are vexing and maybe have you look at it in a different way. So cancer-related fatigue, that is the hardest symptom to treat. And so what do we mean by that? It's distressing, persistent subjective sense of physical, emotional, cognitive tiredness, exhaustion related to cancer or cancer treatment that is not proportional to the recent activity and interferes with usual functioning. Why I like that definition, there's a lot packed in there. So basically, what they're saying to you is, hey, your patient is bone tired, and it's not, even if their chemotherapy was 1 year ago, even if maybe the treatment that they had was not particularly rough, that has no relation to the fatigue. The fact that they had cancer and they got treated for it puts them at increased risk. So another thing with cancer-related fatigue, nobody can actually tell or see this symptom on you. But the prevalence is, and I love science, it ranges from 25 to 99%. So it's really hard to know what that means. But basically, most of your patients at some point may develop this. So 30 to 60% report moderate to severe fatigue during therapy. It usually improves after the first year following treatment completion. And this is something really important that we should be telling patients, because what do they think? They work really hard, they get through the cancer, they ring that bell, and everything's supposed to be fine because that's what they believe, but they're still tired. And they don't understand why, and their families don't understand why. And then we say stupid things like, hey, you look amazing, you look so great, but they feel miserable and they can't go out and they can't do the things that they thought they were going to be able to do or walk back into the life they thought they had. I always like to see this woman here on the couch. She looks amazing, but she's tired. So cancer-related fatigue is severe, persistent, and it's debilitating. And it's not caused by lack of sleep or overexertion, no matter how much you rest. So what I explain to patients is that it's a fatigue of ignition. So I don't know if anybody's ever had an old car, but way back in the day, if your car, you turn the key and the car wouldn't start, and you could still drive it if you pushed the car, ran and jumped in. So what cancer-related fatigue is fatigue of ignition. Once you're doing the activity, you can get through the activity. You might even enjoy yourself. You may not have the same stamina, but you can get through the activity. But the idea of even starting the activity is really hard. I have patients who sit on like their couch and they see their shoes and they can't possibly figure out how they're going to get to put on their shoes. And as vexing it is to us, it is vexing for the patient. So how do you treat it? So again, one of the hardest things. So these are some of the non-pharmacologic treatments, and I tried to show you where the evidence is for them. And why I want to show you this is because the treatment really is the most effective treatments don't require medications. However, the most effective treatments, if you look here, do require money. So if you can't afford cognitive behavioral therapy or acupuncture at $180 a pop, you can't get to a yoga class, your environment doesn't allow you to exercise, there's no way safe, and you don't have good internet, then a lot of these things you're just not going to be able to access, or your patients are going to be able to access. So I love it when patients say, hey, they have cancer-related fatigue, and somebody has said to them, well, maybe you should just get out and exercise, but don't qualify that. So before you make a recommendation, always know what their life is like and what is possible, because that's going to frame your recommendations. And ASCO in 2024 brought together a group of experts who reviewed the literature. And what they found was that there's less evidence for medications for cancer-related fatigue. And so for palliative care, this broke our hearts. But they actually recommend offering stimulants, things like methylphenidate, modafinil, the dietary supplements, the antidepressants like Wellbutrin and steroid, and Wellbutrin, because the evidence for some of it is there, but it's not good enough or very good. And many of these in subsequent studies showed out they weren't much better than placebo. Steroids, however, is still very much appropriate for patients who are at the end of life to help with fatigue, well-being, and appetite. There are going to be some patients, and this was acknowledged in the ASCO updates, that do benefit from time-limited trials of these medications clinically. So that might not be the last word. It may just be that we need better research to really understand what medications are appropriate. So now we come to the other one, insomnia. So how many of your patients have insomnia? How many of us have insomnia? The prevalence of insomnia is over 60% in palliative care patients. I'm actually surprised when somebody says they don't have insomnia. So when we're assessing insomnia, I always explain to patients, they're like, I just can't sleep. And then I start asking them these questions and they're looking at me, rolling their eyes like, Kim, why are you asking me all of these questions? Well, I explained to them that, hey, your body is smart. So if something is not right, like your oxygen level is going down, you're in pain, like you roll over on something that's painful, your body's going to wake you up as a sign to say, hey, something's wrong, you need to change your position, or I'm not getting enough oxygen. So doing that physical assessment before we even think about medications or sleep hygiene is really, really important. So if you're not sleeping, why are you not sleeping? And we need to make sure there's not a medical reason that the body's trying to tell us that something's wrong before we give medications to stamp it out. We got to think about the environment. So really ask these questions like, if you're not sleeping, what actually are you doing when you're sleeping? What is it like? Psychologically, this is always a really good time to, no matter what they put on the questionnaire, to dig a little bit deeper about anxiety, depression. Like when you go to bed, are you able to turn your mind off? Are you ever afraid to close your eyes? So you think about patients who have metastatic disease to their lungs or have maybe had lymphangitic spread, and they present it with extreme shortness of breath. That is frightening. So when they close their eyes, sometimes they're worried that they might not wake up. And then also the PTSD and the nightmares. And then and sometimes insomnia is our gift to them, because some of the antidepressants that we use, opioids, if they have a paradoxical reaction, that Benadryl we give prior to treatment, and many other medications can interfere with insomnia. Interfere with your ability to sleep. So what's the first line and is going to be behavioral therapy. So I say that and I always feel like a collective groan. So why a collective groan? Because in our country, we're socialized to, I got a problem, you're going to give me a pill and I'm not going to have the problem and it's going to be fixed real fast. For insomnia, if there's nothing else going on other than you just have insomnia, it's not going to be fixed really fast. And we need to sort of understand that and educate our patients behind it. Because what actually works and sustains long-term is sleep hygiene, cognitive behavioral therapy, relaxation and mindfulness and meditation. But sometimes that's a little bit of hard sell, and it's hard to hold that line when they really, really want that zolpidem. Also, it's probably one of the best things out of the VA. They produced the CBTI application, completely free, that has been shown to help patients sleep. So I often tell people, if I recommend that app, I'm like, look, veterans use that app and they like it, and that helps them sleep. So if a veteran can use it, then maybe you can too, before we give medications. So oral issues. So why I bring this up is because when we're treating patients, and particularly if they're going to have a good outcome or they're doing really, really well, We mention oral issues, I think, in the pamphlet that we give them, but how many people really just sit down and say, hey, look, this is going to make your mouth dry, and this could lead to making it hard for you to taste things. You might notice some difficulty chewing if you have some older patients, difficulty swallowing, their voice may change. That's really upsetting to a lot of people. When the voice changes, that's upsetting and frightening. And I circled here tooth decay, because what adds insult to injury is to go through a difficult treatment. You're finally in a good place. Either you're living with the disease, it's working, or you don't no longer have to have treatment. And then 6 months to a year later, your teeth start to crumble. You go to the dentist and they tell you, oh yeah, your mouth has been dry. Everything that you did destroyed your teeth. So great. One more thing, because cancer and cancer treatment is a gift that keeps on giving. So what are some of the things that contribute to a dry mouth? Well, think about it. We often contribute to that dry mouth because how many of us give patients opioids? And then if we give them steroids, we give them proton pump inhibitors. Many of our patients are antidepressants. Zyprexa is everybody's fan favorite for cancer-related nausea, antihistamines. So a lot of these medicines we use for symptom management. And many of our patients are on multiple of these medications, not just one. And their mouth is dry, and sometimes they don't make the connection. But we need to make the connection. So if you have somebody on all of these medications or a combination, then we don't need to wait until their mouth is dry and they're hoarse and they can't swallow, and we think they're not eating, because they're depressed or their appetite's low. We need to talk about this before. So talk about hydration, keeping the mouth moist, mucosal lubricants. And I have I promise I have no investment in this company or no financial relationship, but Xylemelt, this over-the-counter mucosal lubricant, comes in these little wafers, and they coat the mouth, and they're great to last all night. It's my favorite thing to use, because the other things are just kind of temporary. Setting them up with humidifier, sugar-free candy. Things that produce spit, those medications have some other unintended side effects, so we tend to use those last. But what's most important is we talk about this, because this actually affects so many different things. Right. If you're not eating, if your teeth aren't good, it's going to be really, really hard to keep your weight. And also thinking about the way you look, all of those things play into how our patients feel about themselves and move through treatment. So mucositis. So we do talk to patients about mouth sores, and we're really good at treating mouth sores. I mean, we give out magic mouthwash. We try to think and be proactive for many of our patients. But one thing I find that, at least that we may not do as well as we could, is explaining the grades of mucositis. So oftentimes by the time the patient comes to you and says, my mouth is on fire and I haven't eaten in a week, you're looking at grade 3 or grade 4, and the cat is already out the bag. What I like to talk about if I know they're going to get a treatment that's going to cause mouth sores, I want to see them at grade 1. I say, grade 1, your mouth is going to burn a little bit, like you ate something spicy, but all the time. The moment that happens, you may not see a thing. The moment that happens is where we're going to need to intervene. That's when we're going to start the oral rinses, the dexamethasone, working together if they're in radiation oncology with our radiation oncologist, but sort of thinking about that and introducing that and normalizing it so patients can be your partner and letting you know the symptoms. The other thing, and I've often explained to patients, particularly those who don't really like to take more medicine, they really don't want to take pain medication. If you are grade 4, they need pain medication. Sometimes they need IV opioids or oral opioids. I've seen people try not to do that, but all you're going to do is prolong and make it so that they're not eating longer, in pain longer, demoralized longer, and possibly not able to tolerate their treatment. Other things to remember is that they can do some things themselves. So cryotherapy or ice lollies, I tell them, when you go to get as your treatment, this is going to sound insane, but I want you to sit there and eat ice through it. Won't completely get rid of the mucositis, but it helps, right? Because cancer treatments are affecting rapidly growing, rapidly dividing cells. So you lose your hair, you get these mouth sores. So if you cold cap your hair, I basically say you're going to cold cap your mouth. So get your hat, get your blanket, get your fuzzy socks. And even though the infusion center has aggressive air conditioning, eat the ice. The bane of many people's existence is the hot flashes, the vasomotor symptoms. So what can you do about that? Well, I want to just go through some of the treatments, things that you might use, things that you might not be familiar with using. So oftentimes we refer people to acupuncture. It's better than placebo, but when they get placebo, it seems to work just as well. So if you have a person who is financially distressed, or even if they're financially on the edge and they have to make some choices, I might not send them for acupuncture. If they can afford it, I'll send them for acupuncture. Non-hormonal medicine. So antidepressants like Effexor, that can be a hard sell. But if your patient gets nervous with Effexor or their blood pressure starts rising, you can use citalopram or paroxetine. Paroxetine, Paxil would be the last on the list because once you start Paxil, it is really hard to get off. So my go-tos, Celexa, citalopram, or venlafaxine. And then if that's not working, paroxetine would be the last. Gabapentin, so I saw vitamin G because we give all of our patients on that, can help. Clonidine, Veoza, and oxybutynin, actually. Problems with these medications is that if you're older, they have oxybutynin has anticholinergic side effects, so you may affect their ability to urinate. Clonidine can go ahead and drop their blood pressure. Gabapentin sometimes can cause sedation and confusion and changes. So you just want to be aware of that as we're giving these medications. So let's talk a little bit about gabapentin. So if you give gabapentin for hot flashes, the flashes are not going to stop tomorrow. So oftentimes it's hard to get people to stay on it. But what you want to give that realistic expectation is, I'm giving you this to help with hot flashes that will occur a month from now. Also looking at the new medication, which is really, really hard to get, the Vesolimumab. Okay, I'm going to call it Veoza, but it reduces hot flashes by half at week 4. So remember, anything you're taking to help with the hot flash, 4 weeks, nothing's working right away. So you want to set that expectation. And then another study showed they had about 50 fewer hot flashes after 4 weeks versus 30% of placebo. Again, tricks, lifestyle changes. What are the things they can do to ride through? So oftentimes I'll tell patients, okay, look, you're having hot flashes. They come at the same time every night. You go to bed, you put down a towel. You have your pajamas. Hot flash, roll up the towel inside of the pajamas, put on your new pajamas, and then you go back to sleep. Stellate ganglion block, if it's really, really bad, this is gaining more traction for uses. You may have a patient that you sent to cancer pain, and tell their cancer pain doctor about hot flash, and they were like, hey, we can do a nerve block, and that makes no sense. The reason why it makes sense is that it tends to help with the vasomotor symptoms. It also is a treatment for PTSD, so more information to come, but I say don't be afraid of a procedure. The next thing I like to cover is total pain. So if you have a patient who has a serious illness of any kind, particularly cancer, particularly if that cancer has affected, their whole entire life, they have pain, and they're likely to have total pain. And what total pain is the pain that you not only experience physically, but the spiritual, the psychological, and the social all rolls up into one ball that affects your patient's ability to not only tolerate pain, but also the perception of pain. So what do I mean by that? So oftentimes when patients have pain and I ask about their psychological symptoms, about depression, anxiety, you can see their face fall. They're almost a little crestfallen because what do they think I'm saying? They're thinking I'm saying this pain is in their head. So what I often show them is this diagram here. And what that diagram here is saying is that it's a vicious cycle. So pain's in the middle and it's like a cog. So if you have physical pain and you get deconditioned, the more deconditioned you get, the worse the pain gets. And it's this terrible cycle. If I just break that cycle, the problem is the psychological cycle might still be turning and still generating pain. So if I just fix your physical symptoms, but don't deal with the psychological symptoms, your pain's not going to get much better. If I only treat your depression and your psychological symptoms, but I don't deal with the fact that you actually, the physical pain of the pain generator, you're not going to get any better. So this is the reason why we have to treat both. And social pain often comes from a loss of dignity. That's what we mean by that. Spiritual pain, in fact, interfering with or changes in what a person might think their purpose is or why this is happening to me. So what is the cause of pain in patients with metastatic breast cancer and survivors? Because even in palliative care, oftentimes patients will get a referral and it'll be somebody who finished treatment in 2017, right? And their oncologist refers them to us for pain. And then our team looks at this and says, well, they haven't had treatment since 2017. Again, that no evidence of disease. How is this related? Maybe they just need to see pain management. So what causes the pain? Well, thinking about the surgeries and the post-mastectomy pain and the lymphedema, we all understand that in the short term, but the problem is with post-mastectomy pain, that pain, everything can be fine, and then all of a sudden, a year or two later, you develop that terrible neuropathic pain. The lymphedema gets a little bit worse. Chemotherapy-induced neuropathy. Many patients will improve. However, if they have to be on the chemotherapy, indefinitely for maintenance, they're never going to be away from the stimulus that's causing the neuropathy. And if they have diabetes, it compounds. And for some patients, even after the chemotherapy, after 18 months, they may just have to live with a degree of that. The bane of many breast cancer patients' existence is the aromatase inhibitor and the joint pain. Because when we say joint pain, it sounds like, oh, you have a little arthritis, a little joint pain. But imagine from your patient, they're like, God, I have a knee, I'm kind of achy. And people are like, why do you want Percocet for that? Or, why can't you just kind of work through it? Imagine if you're sitting, like a lot of us sit, and some people will leave this lecture and they'll go to the bathroom and you'll get in your car. But when you have this kind of joint pain, everything has to be planned because you go to get up and you can't right away. You'll get up, but you stop. And you go to take that walk, and that walk is going to make you feel better, but you're going to hurt for the 10 minutes of it. You want to take down the Christmas decorations, but guess what? It's painful because your joints are painful. You can do it, but it's a constant reminder working on your brain at all times that not only are you taking this medication, but you have this constant reminder of cancer and this constant reminder of physical limitation. Think about radiation, post-radiation necrosis and brachial plexopathy, incredibly painful. Sometimes the medications, I always say, I laugh with patients, because, you know, we'll talk about weight or have you had lost weight, and a lot of patients will say, I gained weight. So not only do I get cancer, but to add insult to injury, now I've gained weight. Who gains weight with cancer? But that weight gain can put extra stress on joints, particularly for your older patients who already have osteoarthritis, impair their ability to move, which perpetuates the pain. And then cancer pain, pain from wounds, pain from the metastasis, even if it hasn't grown. Because what I explain to patients is that you may not have a huge change on your scan, but if you have just a little bit of a change, because we're dealing with spaces that are in millimeters, that cancer could have been not pressing on the nerve, 2 weeks ago, a little inflammation, a little bit of growth, now it is, and now you're in pain. So I say cancer doesn't cause you pain until it presses on something that hurts. And research studies show that approximately 20 to 50% of cancer survivors have pain. 30% of those cancer survivors do not receive pain medication proportional to the intensity of their pain. And pain negatively affects a cancer survivor's daily functional status and quality of life. And that persists for years. So not addressing this really keeps people from re-entering back into their lives and moving on. So I want to talk to you a little bit about opioids. So opioids are recommended for cancer-related pain. They don't outperform placebo, however, for patients with chronic pain. So when we talk about pain, and particularly in survivors, people stiffen up because they're thinking, oh, are you telling me that I need to give them opioids? Are you telling me that I need to give them more medications? Well, no, you don't have to give them more medications. You don't have to give them opioids, but you do have to believe them. So acknowledging that somebody's experiencing something doesn't obligate you or dictate how you're going to treat that something. And even if that pain is driven psychologically, doesn't necessarily mean that they don't experience the pain. They're experiencing it. It's just coming from a different place. But now with the opioid crisis, we do have to dispel the myth that our patients don't get addicted, that our patients don't misuse. There have been several studies that show that if you test everybody who is large swath of cancer patients taking controlled medications, oftentimes you will find things that you shouldn't find in there. Patients will take these medications and chemically cope. So, and people are like, oh my goodness, that's terrible. I said, have you ever had a really hard day and you went out and had a drink? Perfectly acceptable. I have a really hard day. It was pretty terrible. I just want to sleep. I'll take a Percocet. Unacceptable. So when we hear that from the patient, sort of think about, we actually do in our society promote the behaviors. But depending on what we're using, if it's alcohol or over-exercise, a variety of things, marijuana, a variety of things that are not acceptable, that are acceptable, but we stigmatize our patients when they use these medications for things that we experience ourselves. So I just want us to sort of think about that, because that will affect how you approach when patients are using medications inappropriately. So these are the side effects that I don't have to go over them with about opioids, but these are the side effects that you may not know, and we don't often counsel our patients. So the cardiovascular risk is equal to NSAIDs. Some of the medications prolong their QT, methadone, buprenorphine, fentanyl. Immunosuppression, there's opioid receptors on T cells. We don't fully understand why, but it may affect and decrease resistance to infection, particularly in vulnerable populations. Buprenorphine doesn't seem to do this. Endocrine, so this is really kind of where the rubber meets the road. And long-term opioid use can reduce testosterone. It definitely affects our men. and our women as well, increased risk of metabolic syndrome. So now that our patients are living longer, that increased risk for high cholesterol, glucose intolerance. It can promote estrogen deficiency and osteoporosis and increased risk of fracture. So when we start these medications, and it's really hard sometimes when they've been on them for a long time to stop them, they often feel kind of accused. But if I wonder if we really educated people, not just that you could get addicted and you could overdose and not breathe or something like that. What if we told them long term what these could cause, and we really gave them informed consent, and we gave them a true choice? If the way we approach these medications would be different. So if you send them now to pain management clinics or palliative care clinics, many of us will recommend a medication like buprenorphine. So why are we recommending buprenorphine? Because buprenorphine has a better side effect profile. People can be on it for long, but it does come with a stigma because most people associate it with Suboxone or opioid misuse disorder, but it's actually a really fine pain medication. And if you have to be on it, I think that is a safer medicine to be on long-term for people who are going to require chronic pain management. So flipping over to what are the messages that your patients are receiving at diagnosis? And what is some of the unintended harms? So when we look at these pictures, cancers, patients need to be warriors. We need to be resilient. We need to be fighters. We can break down a little bit, but a strong person never gives up. But when we really think about it, for our patients, what does illness actually threaten? It threatens security, confidence, stability, and well-being. And that can lead to demoralization, which is a little bit different than depression. And demoralization affects the way you see life, the way you move through life, increases risk of suicidality. So these patients are living their lives. They're not like depression where they can't get up and can't sleep. They're eating, they look normal, but everything is seen through a negative lens, and they can't seem to move on, or they get stuck. Incredibly important to recognize this and have this treated. This is where you'll see cognitive behavioral therapy, while there's a rise of psychedelics and things like that. And there's more research in this area to figure out how patients can move on and live and learn to accept those symptoms. Also psychological therapy, which sometimes people might be resistant to. So things like acceptance and commitment therapy, helping patients kind of understand that they have this illness and I am accepting where I am. So how am I going to live with it? And remember, if a patient experiences PTSD, they need special PTSD counseling. So I want to just be mindful of the time, and I'm so sorry. I think I am running long, but remember complementary therapies. Your patients are going to use them. So educating yourselves about them is incredibly important, and there is some evidence. So what are some of the barriers? So we'll run through these very quickly. So what patients often are concerned about is that they believe palliative care means an end to curative treatment. So educating them or providing them education or normalizing it. So I say, don't wait to send them to me when the house is on fire. Introduce this concept as something normal. Hey, we're going to start treatment. You're going to meet your palliative care team for your symptoms. Helps normalize it. Healthcare providers sometimes are still worried, less so, but still worried that we might interfere, take away hope. So learning about it, being able to explain to maybe your colleagues why this is important, and embedding palliative care within oncology clinics, actually incredibly helpful. It saves patients having to go to different places to get this care, but it really allows your palliative care provider to understand the illness. When we think about health disparities, of course, there's significant disparities that exist for patients with minoritized backgrounds. I don't have to say it as something that is, but targeted approaches or really thinking about strategies that are culturally appropriate, that are focused, can really be helpful. And we need to advocate, we need to advocate for policies, things within our institutions that ensure that patients receive adequate care. And remember, about only 25% of metastatic patients actually get this care. So I want to leave you with a call to action in the last minute I have here, is access to high quality palliative care delivered by an interprofessional team for advanced cancer is standard. If we don't provide this, we're not providing standard of care. Primary palliative care delivered by oncology teams are essential. Essential being knowing how to do this and naming what you're doing. Patients asking for palliative care doesn't mean they're giving up. They're just asking for tools they need to make it through their journey. We as healthcare providers should fight just as hard for our patients' quality of life as we fight for access to treatment and for cure, because there's no point in doing all of this if the rest of your life is miserable and you regret. And no evidence of disease is a ridiculous statement. The cancer is not over when the scans are cleared. For those patients, a whole other journey awaits. They climb one mountain just to look at another. So I'm going to go ahead and stop here. I do have, I just wanted to thank my institutions that support me, and also thank this organization. And I will stop.
You were amazing. Thank you so much, Dr. Curseen. You shared so much valuable information on so many points, and I really appreciate you covering also kind of barriers to access and the calls to action. I think that'll be really helpful for our audience. We have just a couple more minutes, which is completely fine. We did get some great questions, so if you wouldn't mind, I'd love to just pose one or two to you before we wrap up in a couple minutes. So thank you to our audience for being really engaged and for submitting some questions. I think this is a good one. It may be the only one we have time for, but I think it's really important because it probably resonates with more than just the person who submitted this. They said, I'm an oncology social worker. Occasionally, I've suggested palliative care to a patient's primary oncologist, but I've received pushback because they are associating palliative care with hospice more than symptom management, and they're sometimes resistant to writing the palliative care order. Can a cancer patient refer themselves for an initial palliative care eval independent of their oncologist referral? So I thought you might be able to comment on that.
Yes, they can. And the way we have actually been accepted and integrated is because patients asked.
Oh, okay.
So you asking and sometimes trying to bend, the oncologist ear is difficult. But it's difficult for them to say no when the patient asks. And I also give the patient words to say. So when you ask for the palliative care consult, say, Doctor, I need a palliative care consult. I'm not giving up, and I really want to continue with treatment. I just need more support for this journey. I'm not ready for hospice, but I need more help. And because what you're doing is then allaying the fear, because that's what they fear. Also embedding in palliative care and saying, and being supportive of having clinics embedded, actually get rid of some of that stigma. Working when I first got to my area, not to my cancer center, it was not a welcoming environment. However, when they got to know me and I started to understand what their hopes and dreams were, and understand them as people and understand their practice, then I became accepted and actually sit on their executive council now.
Oh, wow.
That only happens because of relationships.
Great. Thank you so much for sharing your insights with that. And you actually, in doing so, answered another question or addressed another audience question that had come in. So that was perfect. And it sounds like it's relationships, it's process, it's time. These changes often do not happen overnight. I also just wanted to mention that in the chat and in the Q&A, we saw that your comments about no evidence of disease really resonated with a lot of the people today. So thank you for bringing that up. I think that's really, really important.
Yes. Thank you. Yeah, I want to kill that term dead. Please don't write it in your note.
I remember you mentioning it in the presentation that you did at our metastatic breast cancer conference in the spring as well. So I was happy to hear you talk about it again today with our healthcare providers. So at this point, that's all the time that we have for questions. So on behalf of Living Beyond Breast Cancer, Dr. Curseen, I want to thank you deeply for sharing of yourself, of your experience, your expertise today, especially in kind of a trying time in the weather and in the kind of the community where you live. So thank you again. You have been wonderful. And I know this has been really, really valuable to our audience. Thank you again to our audience. And I wanted to recognize again the Centers for Disease Control and Prevention for their support of this program. So thank you everybody for joining us today and for the care that you provide to people affected by breast cancer. We hope you take care, have a good rest of your day and a good weekend and stay safe out there. Bye-bye, everybody. Thank you again.
Bye.
This concludes today's program. You may disconnect at this time. Thank you for your participation.